Okay, good morning. Let's see. For the presentation, I am going to turn video off just for bandwidth, and we can turn it back on later. All right, so good morning. You should see the title slide. So this morning we're going to start with a brief description of who the National Institute for Occupational Safety and Health, or NIOSH, is, just really briefly. Then we're going to present results from three research investigations that we've done on occupational hazards and health effects in dental personnel. So Brie is going to first present exposures potentially associated with lung disease in dental personnel. I will then present non-malignant respiratory disease mortality among dentists, and then Suzanne will present on suicide mortality among dentists. The three studies that we'll be describing each have their own educational objectives. I'm not going to read these because they were in the description of this session, but just so you know, they are here for this presentation. So who is NIOSH? Just really briefly. So NIOSH is the National Institute for Occupational Safety and Health, and we're part of the Centers for Disease Control and Prevention, or the CDC. NIOSH was created by the Occupational Safety and Health, or the OSH Act of 1970, and we were created to conduct and fund research, to make recommendations, provide technical assistance, and train occupational safety and health professionals, all to help assure safe and healthful working conditions for working people. Now, the OSH Act also created another agency you may have heard of, and that's OSHA, or the Occupational Safety and Health Administration. And so I always say if there's one thing to remember about NIOSH, it's that NIOSH is not the same thing as OSHA. And so this just shows how occupational safety and health is divided in the United States. And so on the left are regulation and enforcement, and then on the right are research and prevention recommendations. And so you can see how NIOSH on the bottom right there in green is part of the CDC. It's under the Department of Health and Human Services. And so we have those research and recommendation duties. This is as opposed to OSHA, which is on the bottom left. On the other hand, falls under the Department of Labor and has regulation and enforcement duties. So while NIOSH is focused on those research, recommendations, technical assistance, and training activities I mentioned before, OSHA, on the other hand, is focused on creating workplace safety and health regulations, performing inspections, and enforcing compliance, such as through fines. So we at NIOSH, we don't regulate, enforce, or fine businesses. Instead, we do that research or technical assistance to make recommendations that then businesses can choose to follow. Those research and recommendations that come from NIOSH's work are also used by other agencies, including OSHA, to improve their standards. So ultimately, NIOSH's work is published and shared by various means, including scientific research articles and all kinds of other information dissemination products. Many of these products are tailored specifically to certain industries or occupations to help get the right information to the right folks at the right time. And so NIOSH is also on social media. You can find us at any of these places to learn more through any of these channels or through the CDC website. And so I'm going to turn it over to Brie and her recorded slides.
Hello, my name is Brie Hawley Blackley. I'm a Research Industrial Hygienist at NIOSH. And for today's talk, I'm going to briefly give some background about some of the lung diseases that we have seen among dental personnel. And then I'll also be talking a bit about a study that I've been leading for the last couple of years, which is looking at exposures potentially contributing to work-related asthma and interstitial lung disease among dental personnel working in clinics and clinic labs. So historically, dentistry has not been considered a high-risk job. In fact, in my training as an industrial hygienist, or basically somebody who studies workplace exposures, I had not really thought of this profession until some of my colleagues published an MMWR in 2018, which reported on a cluster of idiopathic pulmonary fibrosis that was observed among dentists. And this publication got me thinking about, what is it that they could have been exposed to? What did they work with throughout their years of practicing as a dentist that could have contributed? And so when I looked into it more, I started to learn that dental personnel do work with or can be exposed to vapors and dusts that can contribute to lung disease, two of which we are interested in learning more about are interstitial lung disease as well as work-related asthma. And so one of the first exposures I wanted to learn a bit more about are the dusts that can be created, basically when a dentist is performing different tasks. And so some of the most commonly encountered procedures where dust will be generated is when a dentist uses the high-speed handpiece, or this is what you might know as the drill. And so whenever they cut into an existing tooth or an existing restorative, they can generate very small particles. They can generate particles that are on the nanoscale size range. And what's notable about this is most of these particles are falling less than 4 microns in size, which means that they're falling into the respirable size range. And that's notable because these are dusts that are small enough to make it into the deepest regions of the lungs. And they're also notoriously more difficult to control because they stay suspended in the air for on the orders of hours to days. And so some of the different constituents that you'll find in these dusts are varied. You can have, of course, natural tooth, as they might cut through tooth. And then you can also contain any other different restoratives that could be present, things like dental composite, glass ionomers, porcelain, acrylic resin, and then any metals that could be present, including things like nickel, chromium, cobalt, molybdenum, and beryllium. And so we do know of several upper and lower respiratory conditions that have been associated with working in these settings. There's some upper respiratory conditions as seen off to the left here, and some of the lower respiratory conditions that we know of are work-related asthma, pneumoconioses, idiopathic pulmonary fibrosis, as well as lung cancer. And so I don't have time to talk about all of these today, but I'll briefly give some background on pneumoconioses and idiopathic pulmonary fibrosis, or what's known in short as IPF. And so the first set of lung diseases I will talk about are pneumoconioses. And so you may already be very aware, but just for background, pneumoconioses are dust-related lung diseases. And so some of the potential exposures in dental settings that can contribute to this include things like silica, heavy metals like cobalt, chromium, indium, and nickel, and then also impression powders. And in fact, when other studies have looked at biopsies of dental personnel with pneumoconiosis, they showed deposits that are consistent with grinding down different dental restoratives and included all of the things that are seen here in this list. And one of the pneumoconioses that are specific to dental personnel is what's known as dental laboratory pneumoconiosis. There's numerous case studies of this observed among dental lab techs, and some of the exposures that have been reported include things like silica, nickel chromium, asbestos, indium, cobalt, and other metals that may have been used. And what I'm showing you off to the right here are scanning electron microscope images of a lung tissue specimen taken from a lab tech with pneumoconiosis, and what the investigators found was that cobalt was present, which was consistent with this lab tech's work-related exposures. And so thinking about pneumoconiosis potentially being observed not just among dental lab techs, but among dentists or other dental personnel who might work in a clinic, some of the exposures, of course, that I first thought of are dusts. And so dust can be generated during various procedures, but one of the standout ones is whenever they grind down either existing tooth, or if they're cutting through an existing restorative or going back in to polish that restorative after they put it into the patient's tooth. These procedures can generate very, very small dusts. And so some of the things that can be generated are things like metals, as I mentioned previously, things like nickel, cobalt, chromium, indium, and molybdenum. These are not the only metals, by the way. These are just a handful of them. There can be many different metals that are used. And then also dentists, if they're working with dental composites or porcelain, these are restoratives that have become more popular in recent years owing to the fact that they are tooth colored, and so they're aesthetically more preferable by most patients. And what's notable about these is that of the handful of studies that have looked at them, it looked at the dust that are generated from grinding through composites. They find that, again, these particles are very small, so they're on the nanoscale size, and they can contain things like silica, which we do know can contribute to interstitial lung disease. And then lastly, there's been at least one case study of a dentist with pneumoconiosis where when they went in and looked at the biopsies of that dentist's lungs, they found that there were powders that were consistent with the production of impressions. And the other lung disease I'll talk about today is what is known as IPF. And so we at NIOSH first became interested in the potential association between IPF and dentistry when in the spring of 2016, my former branch chief got a call from a dentist who was undergoing treatment for IPF at a tertiary care center. And so he let us know that he was aware of at least a few other dentists who were also undergoing treatment there. And he felt like there were potentially more dentists than you would expect being treated for this, but he wasn't sure if there was any grain of truth to this or if this was just anecdotal on his part. So he wanted us to look into it further. And then some of my colleagues followed up with the treating clinicians. And then they eventually collaborated on a study where they described their clinic's experience treating dental personnel. And so what was learned from this was that the number of dentists with IPF was 29 times higher than the number expected. And so there were several key findings that came from this case series. The first is that all of the cases were male. Another finding was that the median age at diagnosis was 65 years, but ranged from 49 to 81. Unfortunately, 7 of the patients had died by the time they wrote this all up. 5 of the cases were smokers, and then again, unfortunately, they were only able to interview 2 of the patients. But when speaking to these 2 dentists, they learned that many of the tasks that the dentist had performed were consistent with typical dental tasks. Nothing really stood out as being a specific hazard or, over and above risk. And the other thing to note from their interviews was that, unfortunately, prior to the 1980s, or basically prior to the AIDS epidemic, it was very commonplace for dentists to not use any personal protective equipment. And so that's just one other finding from this that is notable. And so one thing, of course, that's important to note is that the definition of idiopathic itself means that we don't know what exposures are causing this condition. And so one question that arises when thinking about idiopathic pulmonary fibrosis is, are all cases truly without a known cause? So some scientists at SUNY tried to test this question by taking lung tissue specimens from 30 IPF patients, and then they looked at their composition to try and understand if there were potential exposures that had contributed. And so what they found was that a substantial number, so of the 30, 21, had dust in them with things like aluminum silicates, metals, and then 5 even had evidence of asbestos, and 1 had signs of talc. And so these data indicate that a substantial proportion of IPF cases might actually be caused by environmental exposures. And so to address some of these concerns, NIOSH has undertaken multiple studies in the last couple of years. And so one study I've been leading is focused on trying to understand what exposures might be associated with interstitial lung disease in dental personnel. And so the cluster of IPF reinforced the need to understand exposures in clinics and clinic labs. And so in response, we designed a study that assesses exposures in clinic settings that can potentially contribute to things like pulmonary fibrosis. So our studies focus on exposures to respirable dust, and again, these are dusts that are smaller than 4 microns in size and can reach the deepest regions of the lungs. And then within those dusts, we are assessing the presence of respirable metals and respirable silica. And then as part of this study, we're also assessing any exposure controls that may be present, so things like ventilation, and then any personal protective equipment that might be used. I will take a second to note that prior studies observed that roughly only 40 to 60% of dental personnel said that they used respiratory protection at least half of their working time. And this was often in the form of a surgical mask, which unfortunately does not mitigate these very, very small particles, the respirable size particles and smaller, very well. So this is something that we're taking into account as we go and collect our exposure samples, is trying to understand what exposure controls may be currently being used. And so we aim to assess 21 clinics in total across different specialties. Like I'd mentioned, we're planning to assess respirable dust, silica, and metals, and then also looking at real-time, or what's basically every 10-second measurements of respirable dust and submicron particles. This allows us to look at any jobs or tasks with higher exposures, which would then help us inform exposure mitigation strategies. And so we're just finishing up year 3 of a 4-year study. So we still have another year left on our study, but to date we have gone to 10 clinics and clinic labs across different specialties. And so some of the different settings that we've been to include the setting of a general dentist, which is a dentist who's essentially a jack of all trades that can perform many different procedures that other dentists may then actually specialize in. And some of the specialties we've been to include prosthodontics, which are dentists who specialize in the creation of prostheses for the mouth. So this can be things like crowns or a bridge. And there's also dentists who specialize in periodontics, which are dentists who specialize in the treatment of gum disease, and they also will perform some surgeries. Then of course there's orthodontics, which are basically dentists who specialize in the alignment of teeth. And then one of the other settings we've been to is endodontics, which are dentists who will specialize in the treatment of the root of the tooth. And so what are some of the preliminary results? Well, here off to the right, I'm showing you a graph of measured aerosol concentrations, or measured in different specialties and settings. So on the X, I'm showing you the different specialties and settings, whether it's a clinic or a lab. And then on the Y, I'm showing the total concentration, which is particle number per cubic centimeter. And these are for aerosols that are measuring anywhere between 10 nanometers and 10 microns in size. So one thing to note here is that the aerosol concentrations and composition varied by specialty, but also one big thing to note is that they were very, very small. So the count median diameters for these aerosols were less than 70 nanometers in size. This was across all specialties, so these are incredibly small particles. And the reason why I point out this is because in the next slide I'll talk a bit about some of the mass concentrations that we had measured, which is the typical metric that is used to compare with, say, an exposure limit. And so because these aerosols, or essentially particles, are so small, you would expect them to also have corresponding low mass concentrations. And then so as I mentioned, we had measured very low mass concentrations. So when any of the singular exposures that were measured were compared to any relevant exposure limit, they were all underneath of any relevant exposure limit. And when we looked at the respirable dusts and looked at what was present in those, some constituents that were observed are potentially associated with lung disease. So these can include, I'm not going to go through the full list here, but some of the things that we saw were beryllium, chromium, cobalt, crystalline silica, nickel, and also zirconium. The concentrations of these dusts varied by specialty. And like I had mentioned in the previous slide, we're seeing that these aerosols are very, very small, with count median diameters less than 70 nanometers in size. So it was not surprising to observe that the corresponding mass concentrations were all quite low. But one last thing to note here is that some of these exposures include exposures to things that can cause asthma or cancer, which can contribute to disease at levels well below the exposure limit. And so we're also collecting electron microscopy samples to look at particle shape, size, and content during specific tasks. And so here I'm showing just a couple of snips of some of the different electron microscopy samples during varied tasks. And one thing that is interesting about these is they could potentially be combined with analyses of lung biopsies from dental personnel with interstitial lung disease, and could potentially highlight potential tasks or exposures of concern that could be targeted with exposure mitigation strategies. And so in terms of next steps, as I mentioned, we're only in year 3 of a 4-year study, but at the conclusion of our study, we hope to use our results to inform exposure mitigation strategies that can be used in clinics and clinic labs. We also want to use them to inform any hazard communication materials that we would want to share with dental personnel. And then lastly, they would be used to help design a health and work history questionnaire that could assess respiratory health and work history of dental personnel, which would allow us to assess historical exposures, which is something that we were not able to do as part of this current study.
All right, thanks, Brie. So now I'm going to describe a research project on mortality from non-malignant respiratory disease among dentists in the United States. So we just heard how dentists can be occupationally exposed to hazards associated with lung disease. And, as Brie mentioned, concerns about IPF in particular have received some attention following that NIOSH publication in 2018 that described the cluster of IPF cases among dental personnel at a single tertiary care center. So in order to further understand the relationship between occupation as a dentist and respiratory disease, for this project, our objective was to describe the patterns and causes of mortality, focusing on non-malignant respiratory diseases, including pulmonary fibrosis, among dentists who died in the United States during 1979 through 2018. So we partnered with the American Dental Association, or the ADA, for this study. And the ADA provided NIOSH with demographic information such as name and dental school graduation year for dentists who died during this time period, 1979 through 2018. And then these made up the decedents in our study. This decedent information was submitted to the National Death Index, or the NDI, at CDC. NDI contains death certificate data from US states and territories beginning in 1979 and is considered the most complete source of cause of death information in the country. The National Death Index then provided us with the decedent's underlying cause of death. And then we defined our underlying cause of death mortality outcomes as the following groups. First, non-malignant respiratory diseases overall. Second, some specific non-malignant respiratory diseases that I'll mention. And then third, a pulmonary fibrosis group, or a PF group, of ICD-9 and ICD-10 codes that most closely approximated pulmonary fibroses, including IPF. And then finally, we calculated proportionate mortality ratios, or PMRs, indirectly standardized for age, sex, race, and 5-year calendar period with 95% confidence intervals and two-sided p-values. So we obtained causes of death for 21,928 dentist decedents who were included in our main analyses. 98.4% were male, 95.7% were white. The average age at death was 78.6 years, and the average time between dental school graduation and death was 51.5 years. So this graph is going to display the proportion of deaths from non-malignant respiratory diseases, and the cause of death will be on the x-axis, and then the proportion of all deaths on the y-axis. So 7.2% of all dentist decedents had any non-malignant respiratory disease as their underlying cause of death. For specific non-malignant respiratory diseases, the proportions of all deaths due to these specific respiratory conditions were less than 3% for each cause. So I've put a light blue background over these specific respiratory conditions just to indicate that they are included in the non-malignant respiratory disease overall category, meaning each of these specific conditions are just subgroups of that overall group. So COPD, chronic obstructive pulmonary disease, in orange was the underlying cause of death for 2.7% of all dentist decedents, and then pneumonia in green, 1.9% of all deaths. In red, there was a group of other respiratory diseases that made up 2.4% of all deaths and was a group of less common respiratory conditions. And then finally, 1% of all dentist decedents died from a pulmonary fibrosis or a PF group underlying cause of death. And so similarly here, I've put a light red background over this PF group bar just to indicate that these pulmonary fibrosis causes of death are included in that other respiratory diseases category. And so you can see how that PF group, right, these are those ICD codes that most closely approximated pulmonary fibroses, including IPF. This blue bar makes up about 40% of that other respiratory diseases, that red bar, that category. So I did also kind of wonder, like, if this PF group, this dark blue bar, is about 40% of that red bar, what else makes up the other 60% of that other respiratory diseases group? And so the answer to that is that we found the PF group actually made up the largest percentage of that other respiratory diseases group at about 40%, like I just mentioned. And it is this PF group that we're particularly interested in as potentially being related to occupation as a dentist. That's what we're talking about. Um, the next to largest percentage of that other respiratory diseases group was pneumonitis due to food and vomit. That was 36%, which as an underlying cause of death could be aspiration pneumonia, and not something we would expect to be related to someone's occupation. And then finally, the next largest percentages were other interstitial pulmonary diseases. These would be without fibrosis, and other lung diseases that were less common. And then the remaining portion were respiratory disorders that about 10 or fewer decedents in the whole group had as their underlying cause of death. And so although the specific conditions are included in the overall group, like I mentioned, and then this PF group is included in that other respiratory diseases group, these can each be analyzed separately for the proportionate mortality ratios, and so I'll show that next. So this graph is going to display our overall proportionate mortality ratio results, and the underlying cause of death, again, will be on the x-axis, and then the PMR with the 95% confidence intervals will be on the y-axis. I've put a dark horizontal line just to indicate where the PMR is equal to 1. So PMRs that are significantly different from 1, that is where that 95% confidence interval does not cross 1, indicate that the proportion of deaths from that specific cause among dentists was significantly larger if it's greater than 1, or smaller if it's less than 1, than the proportion of deaths from that same cause among the general population. So for example, for non-malignant respiratory disease overall, proportionate mortality for dentist decedents was significantly lower than the general population. Proportionate mortality for dentist decedents was also significantly lower than the general US population for COPD, that's the orange dot, pneumonia, the green dot, while it was not significantly different from the general US population for influenza and asthma. Finally, the proportionate mortality for dentist decedents was significantly higher than the general US population for the other respiratory diseases category, that's the red dot, and also the pulmonary fibrosis group, that's the rightmost result in the blue dot. So remember here how the PF group causes of death made up a large percentage of that other respiratory diseases category. So that could be what's driving that other respiratory diseases, that red dot, that result. But then when we separated out the pulmonary fibrosis deaths specifically in that dark blue dot on the right, we found an even more elevated PMR. We also looked at proportionate mortality for these underlying causes of death over time. And so this graph displays the PMRs by calendar period, and then the stars or the asterisks indicate where that PMR was significantly different from one. I just had to do it this way because the confidence intervals lines were just going to overlap too much here, so I used the asterisks. So the non-malignant respiratory disease overall, that's the blue line, the COPD in orange, and then pneumonia, that's the green line, were generally significantly less than one, except for some of the results in the earliest calendar periods where the number of deaths from those causes was much smaller. In contrast, that other respiratory diseases category, so this is now the red line, had a PMR that was greater than one during all calendar periods starting in 1995, although the 2010 through 2014, only that one reached statistical significance. And so again, remembering how that PF group causes of death that we're particularly interested in make up a large percentage of that other respiratory diseases group, we also looked at the proportionate mortality for the PF group specifically over time. And so the PMRs for the PF group deaths specifically were greater than one during all calendar periods that had at least one death from these pulmonary fibrosis causes. And these results were significant for all calendar periods, except that first one and then the last ones, and I've denoted those by the NS for non-significant, that in these two calendar periods overall all had smaller numbers of decedents as we would expect. So, this means the proportionate mortality for dentist decedents was greater than the general US population for these pulmonary fibroses during all calendar periods, and usually it was significantly so. So in conclusion, compared with the general US population, dentists had decreased proportionate mortality for most non-malignant respiratory diseases. And these results are consistent with other studies in other countries and could be related to dentists' high socioeconomic status and access to healthcare, in addition to lower smoking prevalence among dentists, particularly in the United States. In contrast, compared with the general US population, dentists had increased proportionate mortality for underlying causes of death associated with pulmonary fibrosis. And we know that there are occupational hazards in dental settings that are known risks for interstitial lung disease. And we also know that IPF can be misdiagnosed if occupational histories or other potential causes are not fully explored. And so our mortality results might indicate IPF among dentists may not truly be idiopathic, may instead be related to a common underlying occupational exposure. And we hope that our mortality analyses on fibrotic pulmonary disease can kind of start to provide clues to this emerging concern in the dental industry. And now I will pass it over to Suzanne.
Sorry, thank you. So I'm going to switch tracks a little bit and talk about a slightly different topic. So in addition to our work with occupational respiratory disease among dental healthcare professionals, the American Dental Association asked us if we could use their data set to also evaluate suicide mortality among dentists. I do want to prepare everyone that the next group of slides will cover suicide and suicidal ideation. So suicide and suicidal ideation among healthcare professionals, including dentists, is a growing concern with significant impact. Dentistry involves risk factors for suicide and suicidal ideation, including experiencing high occupational stressors, such as demanding patient expectations, lack of autonomy, professional isolation, business pressures, practice management, litigation fears, and public perception of dentists. Furthermore, the demanding academic requirements of dental schools are associated with an academic selection process that has led to a high percentage of dentists having a perfectionist personality, or what we call perfectionist personality. And perfectionist personality types are commonly found among individuals pursuing professional degree programs like dentistry and may further contribute to their vulnerability. So when these stressors accumulate without access to resources for support, they can lead to physical harm and emotional distress, potentially resulting in burnout, depression, anxiety, and even suicidal ideation. Therefore, occupational stressors combined with personal characteristics can lead to increased risk of burnout, anxiety, and depression. And then left untreated, these burnout, anxiety, and depression can lead to suicidal ideation. And the purpose of the study was to assess suicide mortality for U.S. dentists, evaluate methods of suicide, and provide suicide trends over time. So this project used the same methods as the non-malignant respiratory disease. So as you remember, our data sources came from the American Dental Association, or ADA, and the National Death Index. The American Dental Association maintains records of deceased U.S. dentists and provided information for U.S. dentists who died during 1979 through 2018. The American Dental Association decedent records provided names, date of birth, and date of death, along with some other decedent information. And then the National Death Index is a centralized database administered by the CDC's National Center for Health Statistics and includes all death records maintained by individual state vital statistics centers since 1979. And decedent information from the American Dental Association that met all the National Death Index data requirements was submitted to the National Death Index to retrieve decedent's underlying cause of death. Final decedent matches between the American Dental Association data and NDI were used to calculate proportionate mortality ratios through the life table analysis system, which was developed by NIOSH. This system was used to compare underlying causes of death among dentists with the general U.S. population. And LTAS requires underlying cause of death and exposure start date, which in this study we assumed the exposure start date to be the year of dental school graduations for all, and then for all decedents and records not meeting this criteria, we excluded them. Deaths caused by intentional self-harm were identified according to the 9th and 10th World Health Organization International Classification of Diseases, or ICD coding system. So when looking at the whole data set that was provided by the American Dental Association that met our inclusion criteria, we had a total of 21,928 decedents who matched with death certificates listed in the NDI. And of those, 21,587, or 98%, were male, and 341, approximately 2%, were female. Then, when we pulled out the decedents whose death certificates listed self-harm or suicide as the cause of death, we identified a total of 475 decedents, of which 459, or 97%, were male, and 16, or 3%, were female. Now, comparing suicide mortality with the general U.S. population, the table on the slide highlights the PMRs for suicide among male and female dentist decedents in our study. The table also provides PMRs for known practice modalities provided by the American Dental Association dataset. So both male and female dentists had a statistically significant suicide proportionate mortality compared with the general U.S. population. And PMR for suicide in male dentists was 2.0, with a 95% confidence interval of 1.8 to 2.2. And in females, the PMR was 2.2 with a 95% confidence interval of 1.2 to 3.5. The PMRs for all practice modalities were greater than 1, although not all were statistically significant. Male dentist decedents who did not own their own dental practice had a PMR of 3.3 and a 95% confidence interval of 2.0 to 5.0. Male dentist decedents who owned their own dental practice had a PMR of 2.2 with a 95% confidence interval of 1.9 to 2.4. And finally, male dentist decedents who were reported as being a member of one of the U.S. Uniformed Services had a higher proportionate mortality for suicide compared with the general U.S. population, with a PMR of 2.6 and a 95% confidence interval of 2.1 to 3.2. Now, female dentist decedents in all three groups had a PMR greater than 1, but were not statistically significant. So this figure shows PMR for suicide by calendar period. The red line at PMR equals 1 would be if suicide mortality among dental decedents was equal to the general US population. When we evaluated suicide PMR over time, suicide PMRs increased over time and were statistically significant, higher than the general US population starting in 1995. When we break it down and evaluate PMRs over time by sex, we note that during 1980 through 1994, PMRs for male dentist decedents varied each 5-year calendar period and were not significant, but were greater than 1 and statistically significant during 1995 through 2018. PMR for female decedents was greater than 1, but not statistically significant during 1995 through 2018. And before 1995, there were no female decedent suicide deaths in our data set. Last, we evaluated Methodist suicide using the underlying cause of death ICD codes provided by the National Death Index. And for male decedents, 62% used firearms and 17% were classified in the hanging, suffocation, drowning group for Methodist suicide. For female dentist decedents, 31% used firearms and 31% used what was classified as hanging, suffocation, or drowning as the Methodist suicide. When we looked at poisoning, the portion of female dentist decedents, which was 13%, who used drug poisonings as the Methodist suicide, was higher than the male dentist decedents, who we calculated to be 10%. So what did we find? So both male and female dentists had a higher suicide mortality compared with the general US population, with increasing mortality from 1995 through 2018. Since 1995, suicide mortality among both male and female dentist decedents was consistently increased each calendar period and was greater than the suicide mortality among the general US population. Previous studies have indicated suicide mortality trends for the general US population are increasing, with suicide becoming the leading cause of injury mortality in 2009. Therefore, it is expected that if nothing changes, suicide mortality among US dentists will continue to increase as well over time. This study highlights the urgent need for action to reduce underlying factors associated with suicidal ideation and suicidal mortality among dentists. And although female dentist decedents showed an equal distribution between firearms and hanging, suffocation, drownings group, the most prevalent method of suicide among dentist decedents was firearms in our study. Interestingly, firearms is the most common method of suicide mortality among the general US population. And in contrast, suicide mortality studies among physicians and veterinarians that included method of suicide reported poisonings as a commonly used method. And this information is important because studies have indicated restricting access to specific methods of suicide used by individuals at risk for suicide can serve as a short-term solution for preventing suicides, thus buying time for more impactful and long-term prevention strategies to be established. So the other thing I want to highlight is the proportion of female dentist decedents was highest for suicide mortality compared with the proportion of female decedents for all causes of death. And this is supported by studies from other countries that reported higher suicide mortality for female dentists, as well as other female healthcare professionals. Furthermore, the number of females entering the dentistry profession has been on the rise since the 1980s. And since 2009, females make up more than 50% of dental school enrollment. With the rising number of females in the dentistry profession, this could mean suicides among female dentists would increase unless steps are taken to improve mental health and well-being. And finally, the information from this analysis can help dental service organizations, mental health providers, and professional dental associations design suicide prevention strategies for dentists. Furthermore, the results from the study can also provide a baseline for future analysis and assess effectiveness of suicide prevention strategies. So I'd like to thank you for attending and allowing us to present this information. And on this slide, we'd like to acknowledge all of the people who helped us with these 3 studies. Thank you.